Hello dear friends, this is a patient of a labyrinthine fistula because of extensive cholestoma. So this was patient presented to us with hearing loss and acute vertigo. When we examined the ear, we noticed that there is a cholestoma in the destroying the mastoid, and then HRCT temporal bone confirmed there is presence of fistula. So whenever we are discussing the fistula, so bony fistulas are three types of fistula according to the classification by Donhofer, and there is one more classification by Alba and Ramsey-Hunt. So simpler classification is of Donhofer, which we mostly follow while closing the fistula. So here, like you are seeing, so we have first started drilling, and this patient we know is going to have a big cavity. So we are going to collect some bone dust. So this is very good way of obliterating the mastoid cavity. Practically, it's very nice. Theoretically, it may have some controversies, but practically this method is very good. So you collect lot of bone dust before you start actual drilling. So we have collected the bone dust, and then we make a bone patty out of that. So now we are slowly progressing towards more drilling. So here, so this video is in bit high speed, but the message is to clearly drill the boundaries. So now one side you have seen, you're trying exposing the segment sinus, and other side we'll just expose the tegment. So once we expose the tegment, we have only landmarks, and then because already there is automastoiditis here, so attic is fully destroyed here. So now slowly we are going to drill the attic, and then we started have to follow the cholestoma. So here we can see the cholestoma flakes are there, and now we have to slowly follow the cholestoma flakes where they are getting. So this is a big cholestoma, and it has completely destroyed the membranous labyrinth, bony labyrinth I mean. So according to the Donhofer classification, type 2 fistulas are where there is just blue lining of the fistula, and type 1 fistula are there where it's just a blue lining of fistula, and type 2 fistulas are the fistulas where there is, along with the bony erosion, endosteum is also exposed, and type 3 fistula where endosteum is also damaged and paralymphatic space is fully involved. So normally we'll have in cholestoma type 1 and type 2 fistulas. Type 3 fistulas generally in mass or any cancer which are fully eroding the labyrinth, or any benign or cancerous mass which is invading the labyrinth. So in cholestoma normally we'll have type 1 and type 2, and they often get symptomatic. So in this patient you see, so slowly we are started to expose the mastoid cavity. And now very important is drilling the facial area. So here we are exposing the facial. So now you see, so we have there are two ways of dealing with this, either outside in or inside out. So here, because we have to collect the bone dust earlier, and that bone dust has to be clean, so we decided to have outside in method. So whichever method you are comfortable, you can follow for mastoid surgery. So here you see we are exposing the cholestoma. The no attempt has to be made the prior extraction of cholestoma. First you just expose the cholestoma. Now the moment we lift the cholestoma sac, you see the fistula is coming into the view. So this is the fistula is the dome of the lattice hemispheric canal, and it is the most common area where you will have iatrogenic fistulas also, and then also the fistulas by the cholestoma or any infection or granulation. So once we know we have exposed the fistula, try not to expose too much or deeper into the fistula, but for the moment just leave the fistula alone and try do the full mastoid surgery first. So now here you are seeing, so mastoid cavity is not very big cavity here, so we have to slowly make the boundaries, and then very important is to make a good extraction here. So for that we need to fully expose the facial nerve, and our concept is to that if you fully expose the facial nerve in such extensive disease like this, you have a good chance to expose the sinus tympani area, and then all the disease from the facial recess area and around window area and sinus tympani and all the hidden areas can be easily seen. So now we are keeping eye on the fistula. We're not doing anything to the fistula right now. So we don't want any exogenous material should go inside the fistulous area, so better the leave fistula for alone as of now, and then start doing the fascial ridge area. So here we are completely lowering the fascial ridge, and also the best way is to lower the ridge for open cavities is once you see where the facial nerve is is there, so just try to expose the facial nerve fully. So you keep on following. The biggest fear of any mastoid surgeon is that to injure the facial nerve. But if you know you have facial nerve in view and you have identified the facial nerve and you take the bone of the facial nerve around that area, the chances of injury to the facial nerve is hardly anywhere near. So now, so the full annulus area we have exposed, and then this is the full retraction pocket was there. So it was completely adhered to the promontory, the tympanic membrane. So we have exposed, we have lifted the tympanic membrane, and then once we have lifted the tympanic membrane, this area is a posterior buttress. So also it can cause sometime failure even after from a big metaplasty. So try to remove that area fully. Now we are coming to the fistula. So we are taking the granulation. Now you see it's a very big fistula. So it is most likely a type 2 fistula, and where the bony labyrinthine and osteum is eroded. So in such a fistula, you have to plug the fistula by a cartilage. If only superficial fistulas are there, you can just put a temporalis fascia. But fistulas like this, you need to plug with a cartilage, and cartilage is a very good material. So after the plugging of the cartilage, now we started to obliterate the cavity. So here we are just obliterating the cavity, like you see. So it's a bone patty with antibiotic ear drops, and then along with that, so we have some cartilage piece which we have harvested from the concha, and then we close the area with the concus. There is no point in vascular reconstruction because patient already have a good amount of hearing loss, so there is no, and that is to a sensory hearing loss. So our aim is to give a very clean cavity so that patient might have a chance of hearing aid uses later on. So here we are just placing the tympanic membrane after obliterating cavity fully. So the remnant skin is very important, and remnant tympanic membrane is very important, so it gives a very good healing and very quick healing, and all the remaining exposed bone part of the bone should not be left exposed. So try to cover as much as the exposed bone fully. So here we are using small pieces of temporalis fascia which we harvested from the big graft, and then required graft we have used, and the remaining area we have just covered with remnants of cartilage and then bone patty. So after that we are going to close and then give a good metaplasty. Thank you so much.